Hello, everybody. Good morning. My name is Nick Macaluso, one of the PGY1s. Today, I will be discussing trauma in pregnancy as part of our visual diagnosis lecture series. So visual diagnosis kind of encompasses a range of topics, radiology, pharmacology, EKGs, and it's meant to be very interactive. So I appreciate any and all audience participation, even though we're on Zoom. So please unmute because I also don't even know where to find the chat anymore. So we'll start off with a case. So we have a 31-year-old G1P0 female. She's at 32 weeks gestational age, no prenatal care. She's brought in by EMS to CCT, status post-fall with lower abdominal pain. The story from her is she slipped in water, fell on her right side, and she's now having lower abdominal cramping. Denies any loss of consciousness, head trauma, or seizure. Also denies any leakage of fluids or vaginal bleeding. Taking a look at her vitals and her finger stick, they seem within normal limits. So we'll move on to her exam. Primary survey is intact, GCS 15. On abdominal exam, she has a gravid abdomen with lower abdominal tenderness, no bruising. External pelvic exam is significant for moderate blood at the introitus. She has no external signs of trauma, and a speculum and bimanual exam are deferred. Can anybody call out any like labs, orders, consults, or just things at the bedside, initial actions you would take here? Is there something in the chat?
I'd probably want to do like pre-op labs, get a GYN consult, maybe do a bedside sono as well.
Awesome. Yeah, all good thoughts. So here you'd probably get like the rainbow set of labs. So like CBC, CMP, coags, 2 type-in screens, BBG, HCG. Fibrinogen is another helpful lab to get here. We use fibrinogen as like a marker of severe obstetric hemorrhage. And then things you would do at the bedside, you'd want to place 2 large bore IVs, at least 18 gauge in the setting of bleeding, put the patient on the cardiac monitor, give supplemental O2 as needed, grab the ultrasound for the fast exam, and then kind of depending on your findings, emergently consult OB. So today's talk, again, we'll be covering trauma in pregnancy. Here we have a photo of a ghost bat receiving her transabdominal ultrasound to confirm IUP. Hopefully by the intern on Gynsano. So for today's talk, we'll start by covering physiologic changes in pregnancy before we dive into assessment of trauma in pregnancy. Trauma is actually the #1 non-obstetric cause of death in pregnant patients, so it's a really important area to review and be comfortable in. We'll focus mostly on resuscitation of the mom, but we'll also briefly cover management of the fetus. One topic we will not cover is perimortem C-section, which has been covered in previous talks. And then we'll end by revisiting our case. So going into the physiologic changes in pregnancy. So you may recall that in pregnancy, we have new normals for many vital signs and laboratory studies. So in order to appropriately pick up on subtle abnormalities, it's important to be comfortable with the expected changes in pregnancy. So again, here I will love some participation. We'll start with vitals. So starting with blood pressure, do you expect blood pressure to be increased or decreased in pregnancy?
Decreased.
Awesome, thank you. Yeah, so we would expect actually both systolic and diastolic blood pressure can fall like 5 to 15 millimeters of mercury in the second term, although blood pressure can often normalize by term. And this can often be exacerbated by compression of the IVC by the gravid uterus. How about heart rate? Yeah, I see a thumbs up. So heart rate is expected to increase up to 10 to 15 beats per minute by the 3rd trimester. You may recall that cardiac output increases in pregnancy, both due to increases in heart rate and stroke volume. One caveat to this is there is a ceiling. So if heart rate is above 115, you don't want to just chalk this up to physiologic changes. You want to do a little bit more examination and evaluation for why the heart rate is so high. Moving on to labs, so we mentioned CBC is one of the first labs we would get. Do we expect hematocrit to be increased or decreased in pregnancy? So hematocrit actually would be decreased, 32 to 42% in pregnancy versus 36 to 47% in non-pregnant patients. You may recall this concept of the physiologic anemia of pregnancy. which refers to the fact that there's an increase in plasma volume during pregnancy that surpasses the increase in red blood cell production. For the rest of the CBC white blood cells, do we expect these to be higher or lower in pregnancy? These can actually be slightly increased. It's not entirely understood why. And again, there's a ceiling. If somebody has like a fever and a raging white blood cell count, you don't want to just say that this is normal, but the new baseline can be like 12 to 16 thousand white blood cells, sometimes can have a left shift as well as increases in various precursors. And then finally, another lab that you'll likely draw when the patient comes in is a blood gas, maybe a VBG, but particularly the arterial pH. Do we expect to be increased or decreased in pregnancy? So it can actually be slightly increased to a level of like 7.45. This is because there's an increase in progesterone in pregnancy, which increases alveolar ventilation, causing a mild respiratory alkalosis. So these are just, again, some normals to be familiar with before we move into our assessment of trauma in pregnancy. Anytime you have a pregnant patient in a trauma, it's going to be a high stress environment because you really have two patients in one resuscitation bed. But it always does come back to your ATLS basics. So you don't want to forget your ABCs. The first step to assessing any patient in trauma is your assessment of airway, breathing, and circulation. And this is no different in pregnant patients. And actually something to keep in mind is to best optimize resuscitation success for the fetus. So you want to first stabilize and assess mom. So we'll kind of run through the ABCs, starting with airway. So anatomically, pregnant patients can be very difficult airways. If you take a look at this patient here, you can imagine that if you were approaching her to intubate, this would be a kind of scary intubation. But taking a look at the right, just with some small changes with ramping and better like head, neck support, the positioning is much better here. Another common question that comes up if you're approaching intubation of a pregnant patient is, which induction and paralysis meds to use. And for my research, there's really no clear indications on which are the optimal drugs or any contraindications for particular drugs. Most of these fall into category B and C, and there's limited research in both humans and animals. So the benefit outweighs the risks, and there's no real harm seen even in drugs that were found to cross the placenta. Continuing our discussion of airway and breathing, first covering airway. So in addition to the anatomic concerns from the previous slide, remember that pregnant patients have inherently difficult airways based on changes secondary to the increase in progesterone. So these patients are going to have increased airway edema and vascularity. And the takeaway here is really just to make sure that you are properly setting up before you start intubation. So you want to have like your sheets nearby for ramping, you want to have suction at the hand if needed, and then you want various backup equipment, the glide scope, LMA, or any airway adjuncts if your initial intubation attempts fail. Moving on to the B in your primary survey, consider the respiratory and metabolic changes in pregnancy. So pregnant patients have both reduced functional residual capacity because there's compression of the lungs with the gravid uterus, and they also have increased oxygen demand, oxygen consumption due to increased metabolic demand of pregnancy. So both of these put these patients at an increased risk of oxygen desaturation. So the takeaway is you want to have a really low threshold for giving supplemental oxygen. You want to pre-oxygenate before you attempt intubation, and you really want to maintain maternal levels above 95% and pay close attention to the monitor once the patient is on it. And then the final note here for gastrointestinal, some additional physiologic changes in pregnancy are that there's decreased lower esophageal sphincter tone as well as delayed gastric emptying. And both of these are going to put these patients at increased risk for aspiration during intubation. So a tip is to place an OG or NG tube for gastric decompression before you approach intubation. One more concern for your B in your primary survey is if a pregnant patient in trauma comes in and you detect a pneumothorax. Does anybody know what changes we make for the chest tube location in pregnancy? So keeping in mind that your non-pregnancy location is the 5th intercostal space, mid-axillary line, we just go a little bit higher here, so like the 3rd or 4th intercostal space. And this is, if you take a look at this diagram on the right, just to keep in mind that again, with the gravid uterus increasing with gestational age, your thoracic anatomy is becoming more and more compressed. So you're a little bit safer if you go a little bit higher in these patients. Rounding out our primary survey with C, circulation. So administration of fluids or blood products in the setting of hemorrhage actually follow the same ATLS guidelines in non-pregnant patients, but some additional concerns do come up. One is with safety of pressors in pregnancy. So one thing you want to keep in mind is that the placenta is highly susceptible to pressors since it's highly vascularized. And so there's a risk of decreased placental perfusion. If you give pressors and the fetus may already be in a state of distress. However, with this said, pressors are still safe to give, especially if your fluids are inadequate in restoring patients' pressures. And there are no clear guidelines on like first line or optimal pressors in pregnancy. An additional thing you can do at the bedside is if your pregnant patient is hypotensive and is just kind of supine, there's this concept of like manual urine displacement. And there's a picture here, there's two ways you can go about doing this, the one-handed versus the two-handed approach. But essentially what you can do is try to displace the uterus from compressing the IVC by manually displacing it to the left. And some studies say that this can increase cardiac output by up to 30%. Additional considerations after your primary survey has been complete, you may be now thinking about initial imaging that you want to do either at the bedside or in radiology. So with the FAST exam, again, the ultrasound is probably one of the first things we'd grab when this patient comes in. The FAST exam is actually less sensitive for fluid in pregnancy than in non-pregnant patients. Various studies quote sensitivity between 64 to 98%, so kind of a large range. One large scale study I looked at detected sensitivity to be 61%. And specificity 94% compared to 71 and 97% respectively in non-pregnant females. But one important thing to keep in mind is that sensitivity does decrease with increasing gestational age because as the uterus is growing larger, it can compress the paracolic gutters where we would expect free fluid to collect and be seen on the ultrasound. An additional concern that comes up is the safety of CT in pregnancy because of this worry of radiation risk. But actually, according to the American College of Radiology, doses of radiation less than 50 milligrays are not associated with increased fetal risk of abnormalities. And if you were to get the full trauma scan in a pregnant patient, so CT head, C-spine, chest, abdomen, and pelvis, you would only be exposing the patient to 25.2 milligrays, which is well below that threshold of 50 milligrays. And an additional consideration is IV contrast, but it's actually category B in pregnancy, so it's okay to use if indicated. Moving on to another concern in pregnancy, when we spoke about labs earlier, we mentioned a type-in screen. The picture here has 3 tubes, but remember you should be drawing at most 2 if your patient comes in. So a significant potential cause of morbidity in trauma of pregnant patients is de-alloimmunization caused by fetal red blood cells gaining access to mom's circulation, especially in Rh negative patients. And as we know, administering RhoGAM to these patients provides anti-D immune globulin, which then can suppress mom's immune response to these D positive fetal red blood cells. So this question of when we give and don't give RhoGAM, you want to keep in mind that it's indicated in Rhd negative patients in the setting of abdominal trauma or vaginal bleeding in a trauma setting. And this is because your concern here is partial or full placental abruption where there would be mixing of fetal maternal blood. When it comes to dosing, there's various resources that based on trimester, but actually you can probably always give 300 micrograms IM. Some resources did say that you could give like a smaller dose of 50 micrograms in the first trimester because the fetal blood volume is much smaller then. But 300 micrograms is the standard dose. It's more readily available, and there's little to no harm in giving this to all patients, regardless of trimester. And then one additional consideration, this one comes up after you've already resuscitated and stabilized the patient. You may be starting to think about dispo. You want to keep in mind in all traumas, but especially in pregnancy, there's an increased risk of intimate partner violence. One study that I came across cited that 17% of injured pregnant patients report trauma at the hands of another individual, and 60% of these patients experience repeated episodes of intimate partner violence. So if you suspect IPV, or if the patient already tells you, you really want to get social work involved ASAP. And if the situation is a little bit more subtle or not as clear, there are various like screening tools or questionnaires available to help you better assess for safe dispo in these patients. So now mom is stabilized, so you are able to turn your attention to the fetus. So in assessing the fetus, one of the like top recommendations I came across in all resources is that you really want to get your consultants on board early. So we already spoke about like the importance of an emergent OB consult, but if things were a little bit more precipitous than in the case we initially thought about, if delivery seems imminent, then you additionally would want to get like peds or the NICU in the room as well. The takeaway here being that it's better to have more consultants available and then you don't need them rather than being in the room alone and realizing you need more help. So one of the like most useful tools that we have in trauma of pregnancy patients is cardiotachography or fetal heart rate monitoring. And this is because fetal distress can actually be a very early sign of placental abruption. Transvaginal ultrasound actually does not have great sensitivity for abruption. It can be around like 25% according to some studies. So fetal heart rate monitoring is especially important. If the patient is greater than 24 weeks, you want to monitor fetal heart rate for at least 4 to 6 hours. But if there are, say, like concerning findings on the fetal heart rate strip, or if the patient doesn't seem to be doing well clinically, you would extend this monitoring for up to 24 hours. Signs of fetal distress on fetal heart rate monitoring. Does anybody remember any of these? I can share. One would be fetal bradycardia, so rates less than 120 beats per minute, as well as fetal tachycardia, so greater than 160. On the tracing itself, if you're seeing absent heart rate variability with contractions, or especially late prolonged decelerations, so this may be like a callback to your OBGYN clerkship or your time on L&D, but we have this mnemonic of veal chop when we're considering fetal heart rate tracings. The first three categories are a little bit less relevant here and a little bit less concerning, but the last one here, so late accelerations, is concerning because it can be a sign of placental insufficiency or in the context of trauma, fetal hypoxia. So just to take a look at an example of a fetal heart rate tracing curve here, just to orient ourselves. So the top half is the fetal heart rate tracing, the bottom is uterine contractions. A brief word on the placement of these tochometry monitors. So it's not something that's like regularly done in CCT by us or even by the nurses. But it doesn't seem to be too difficult if you're familiar with Leopold's maneuver for estimating fetal position and gestational age. What you essentially do is you like palpate for the uterine fundus and you place the uterine transducer over there, and then you try to assess for the fetus's back and then place the fetal transducer on that position. And you're able to pick up these two curves. What I want to draw your attention to here is that with the first and third contractions, or the peaks on the bottom diagram, the fetal heart rate drops towards the end of the contraction, so after the contraction peaks, and this is what refers to a late deceleration. So again, these are really concerning because they can indicate fetal hypoxia. So that rounds out our discussion of assessment of both mom and the fetus. So we'll go back to our case. Just to reorient ourselves, this was the one-liner on the patient. Again, she was hemodynamically stable, but she did have lower abdominal tenderness and moderate blood at the introitus. Your labs that you collected start coming back. You see her hemoglobin, her coags are within normal limits, but she is Rh negative. OB comes down, helps with some fetal heart rate monitoring. You see that the fetal heart rate is 110, no late or prolonged decels. So 110 is actually like a little bit on the cusp of being on the like lower limit of normal versus bradycardia, but looks okay for now. But then you grab the ultrasound for your fast exam, and this is what you see. So for the sake of time, I'll just share this is placental abruption. You could draw your attention to this like posterior hypoechoic area that's concerning for blood posterior to the uterus. So next steps based on both this and our findings on the previous slide, we're going to want to give this patient RhoGAM because she was Rh negative. We can give her the full dose, 300 micrograms IM. And then if OB was not already in the room, we would really want an emergent OB consult. There are a few different things they could do for us here. another callback to your OBGYN studying maybe the Kleihauer-Betka test, which can assess if there's ongoing maternal and fetal bleeding and if there are additional doses of ROGAM are needed. And then also they would help us with continuous fetal heart rate monitoring for the next 4 to 6 hours at least. Dispo for this patient is an important question. Is she going to stay down in CCT forever? So actually, since both mom and fetus are relatively stable and the patient is at less than 34 weeks, we will utilize expectant management here. There's no need for her to be like rushed to L&D for delivery. There would be some additional recommendations that OB may make, like antenatal steroids, but that's kind of beyond our scope. And then as for where the patient would actually go, it really depends on the full clinical picture. Sometimes if there is an additional concern, say like a long bone fracture, these patients may be admitted to the trauma service versus if they're going with OBGYN for the fetal heart rate monitoring. Of note, something we clarified with Dr. Beta is if these patients are to go to the ICU, cardiotocography is actually available by our ICU nursing, which is good news. So in summary, here we have a slightly edited x-ray of a pregnant painted turtle. And she herself is actually a trauma patient. You can see she's actually missing her left arm. According to the caption for this photo, she was hit by a car, but she ended up doing just great. But in summary, we reviewed our physiologic changes in pregnancy, special considerations with our primary survey for trauma in pregnancy, and we briefly visited the concept of fetal heart rate monitoring for fetal distress on cardiotocography. These are my sources, and I want to give a special thanks to the visual diagnosis team for all of their help with this presentation.